This is going to be the last time that we have this program until February 2014. So we just want to thank you all not only for coming today, but for many of you for supporting us all season long and for coming every Thursday. We love seeing you guys here every week. So we look forward to seeing you back here again in February. Thank you for coming. If you haven't already, please now is the time to silence your cell phones as not to disrupt the presentation. Thank you for supporting this free community program, which is supported in part by a grant from the Nantucket Cultural Council, a local agency, which is supported by the Massachusetts Cultural Council, a state agency. We are thrilled to welcome today's speaker, Peter Swenson, who has served as the Executive Director for Family and Children's Services of Nantucket since 2006. Prior to arriving on Nantucket, he was the Executive Director for the New Hampshire Teen Institute and Keystone Hall in Nashua, New Hampshire. During his time there, he received the Jefferson Award of Excellence for his work with young people, as well as a Lifetime Achievement Award from the New Hampshire Alcohol and Drug Counseling Association for his work in advocacy for treatment and prevention services. So please join me in giving a warm welcome to Peter Swenson.
I turned on? Yeah, okay, good. Thank the NHA for allowing me to be here today and to present on this topic. Today I'm going to try and cover some areas around alcohol and other drug addiction, as well as mental health issues, and how we can provide assistance for that at Family and Children's Services of Nantucket. As was told, my name is Peter Swenson. I'm Executive Director for Family and Children's Services on Nantucket. You see my phone number and email address up there. And feel free, if you have any questions after today or at any point, and you have any questions about any of these issues or any way that Family and Children's might be able to help you, to contact me either by phone call or through my email. I'm more than happy to respond to that and to try and, if we can't provide assistance, find somebody that can help out with that, or another organization, because there's a lot of great human service organizations and other organizations on Nantucket that can be tremendously helpful. So what is Family and Children's Services? So, there we go. To give you an idea of what we do, these are some numbers that are based on real people that we have seen and the numbers of free service that we've put out over the year. Family and Children's Services is a community-based mental health and substance abuse treatment organization here on Nantucket. We're over in Gwynn Village, which is right across from the hospital off of Vesper Lane. And we are an outpatient-based clinic, which means that people come and see us. We also have programs called, that are home-based services that we provide, where the counselor actually goes and works with the family themselves at their own home, which is really an ideal way of working if you're going to be working with children. Because a lot of times when you work with kids, having them come and sit in an office to talk to a counselor is not a really great way of getting that kind of service to a child. But being able to be with them at home in a place that they're comfortable and where they feel safe and cared for is a great way to work with young people. It's also helpful for a lot of families when they don't have a lot of time to be able to have somebody come and talk with them directly, so that they can just be at home doing what they need to do and to have the counselor there in a really non-threatening kind of a way. So we provide traditional outpatient at our office. We also provide home-based services, which is something that we really think is very valuable here on Nantucket. We also have the issues around confidentiality here on Nantucket, and we take that very seriously. And if you're seen coming down into our offices, some people feel uncomfortable with that because they know that that's where our offices are and other people do. But if somebody just shows up their house, they don't know who they are. Could be a friend visiting or something like that. So it's another way to provide some protection for a person's confidentiality. We have two different psychiatrists that work at our clinic that provide medication. One of them is an adult psychiatrist, and she's here every week. She comes every Wednesday, or doesn't come, she lives on island. Her name is Lori Robertson, and some of you may know Lori. She's also an artist and is really a neat person to have on our staff. But she's here every Wednesday and sees adults at our clinic. And then we have a gentleman that comes over 2 times a month. He lives on the Vineyard, and he provides adolescent child psychiatric services. Prior to my arrival here in 2006, if you needed adolescent and child services for psychiatric care, you had to go off island to get that. And if any of you have had children or have children, can imagine the difficulty that entails. One, you have a child that needs some kind of a psychiatric assistance with medication, and two, you have to leave the island to go do that. So it's not as simple as just going to the doctor's office and having a half-hour visit. You actually have to leave the island and come back, and that could take a day. And the child misses that day at school, it disrupts the family. So we take a lot of pride in the fact that we have an adolescent child psychiatrist that comes to the island and meets with people here. The other thing that I think is important is the amount of free care that we give. It's usually right around that number, about $150,000 to $170,000 a year in free care. And that's for people that don't have any other means of paying. We like to think in Massachusetts that everybody has insurance, and it's nice to say that, but what we have found out in working in the field in Massachusetts, that's not always the case. We have a lot of people who choose not to have insurance because the penalty to not have insurance is actually less than the cost of having insurance. So we do have people who choose to pay the penalty rather than buy insurance. That may not be a smart long-term plan, but when money is really tight, people make decisions like that. We also have plans in Mass Health where a person can get medical coverage for physical ailments, but their mental health services aren't covered, which again is another difficulty that we have, which can be a problem. We then have people who have insurances that don't cover specific things that we offer. It could be anything, private insurances, Mass Health, anything like that. And then the last one that we struggle with, and the people on the island struggle with, is if you have Mass Health and you get a certain kind of coverage and your income changes, they change your coverage. And how they do that is they send you a letter in the mail telling you that your coverage will change on this day. And we all know that that can take time to get mail on Nantucket sometimes. And a good example is that just recently we had a family that was covered for services for their 2 children and for one of the parents, and they probably have 3 or 4 visits a week, getting some really very much needed help. And they got a letter from Mass Health that was sent 3 weeks earlier telling them that their insurance would be ended the next day. And we can't stop providing service for that family because they really need it, and that's what they're expecting. It's not their fault that Mass Health didn't respond quickly enough for them to make other plans and other arrangements. And once your insurance changes, you have to wait till the next period to enroll again. It's a very difficult transition for a lot of families. Mental illness, just to go over really quickly a couple of things. Mental illness is usually something that people are familiar with. A good one would be depression, anxiety disorder, things like that. It's marked by an alteration in how people think or what their mood is. A lot of people think that depression is just somebody feeling sad, but it's not really that. It can be to the extent that somebody has trouble even getting out of bed. Their eating patterns change. They either gain weight or they lose weight. They don't have the ability to cope with everyday problems that other people would just take for granted. So it actually alters their way of thinking. It alters their mood. It alters their ability to cope and to handle situations. And that's what we look for when we're looking at a mental illness. Some of it's very, very obvious. You think of the extreme mental illness where you see somebody acting in a very, very bizarre and strange way, and that's the one that usually catches the attention of our society. But the reality is that depression is probably the most significant mental illness that we have. As the slide says that we have 26% of the US adult population suffers from depression. So that's 1/4 of our population with just depression alone. Not talking about other kinds of mental illness that we might see and experience with people around Nantucket, around Massachusetts, around our country, and also it doesn't include children. So when we talk about mental illness, one of the things that's so difficult for people is the stigma that is put on people with mental illness, thinking there's something wrong with them, that they're not as good as other people, that they're different, that they should be able to take care of these problems themselves without needing assistance or help. And that blocks people from going to get help. What we know is that about 10% of the people with a diagnosed mental illness actually access mental health services and get that service treated in a timely fashion. And what we mean by that is it hasn't impacted their life in such a way that they've had a family breakup, they've lost their job, they've had something really tragic happen to them, and that means. So this stigma that is attached to mental illness is very, very difficult for people who are struggling with that to deal with. And when you think about the numbers, 1/4 of the population with just depression, it kind of makes you pause and think about, why would that be? When 1 out of 4 people you meet is probably struggling with some level of depression. It's pretty shocking when you break it down to that level. And then they're not able to get the help for that because they're afraid of what might happen to them, what might be said about them. You can talk to a lot of people who have mental illness, and they'll tell you that even though they're being treated now and they're on medication and things are fine in their life, they still don't want to tell people about it. I have cholesterol problems. I take Crestor. I exercise, I run, I eat right, I do everything I can to take care of myself. And that, I can tell people that, and it doesn't even cross my mind. I know people very close to me that have any number of different types of mental illness, depression, they take their medication, they do everything that they're supposed to do, and you'd never know. But still, they struggle with talking about that in public. And that's one of the reasons why we try and get out and talk to groups like this, because it really does need to be something that becomes normalized and people can feel safe to go out and get help for it or talk about that. Substance abuse is something else that we deal with at Family and Children's Services. It's probably one of the most significant problems on the island right now. And usually in any community, alcohol is your #1 public health problem because of the consequences that we see as a result of misuse and abuse of alcohol. There are a lot of other drugs that people get involved with and do all kinds of stuff like that, and they might be a little more flashy to talk about, cocaine or heroin or something like that because they grab the media attention. But alcohol is the #1 drug of abuse in the United States, in Massachusetts, and in Nantucket. And it's something that we should all be very, very well aware of because it impacts not only the individual, but for every person who has an alcohol or drug problem, there are 10 other people surrounding them that are directly impacted by that particular person's issue. So when you think about that, everybody that you know is somehow affected by somebody else's alcohol or drug problem. That's a kind of frightening statistic as well. What alcohol or substance abuse is that it's a pattern of alcohol or drug use that causes problems in somebody's life. Now, if it's a child, and by child I'm talking, what we know now is that 5th grade is about the average time for a child to first experience some kind of a substance use. When they end up in treatment and we talk to them about that, we're finding out that most of them are starting around 5th or 6th grade. So when you're thinking about that, talking about having a drug prevention program in the high school, we're too late. It really needs to begin specifically related to alcohol and drugs around 5th, 6th grade. But prevention work should really begin right from the time the child is born. When we talk about healthy choices, we talk about values, and we talk about that kind of stuff. I'll maybe go into that a little bit later. But what happens is, let's take a student, starts having use of alcohol, and then their grades become impacted, and everything starts to go downhill. Their friendships are impacted, their relationships are impacted, their home life is impacted. And what the problem with addiction is that it doesn't seem to matter when somebody becomes addicted. They just keep moving forward in their addiction, and the alcohol or the drug or what have you becomes more important than the other stuff. It's a real challenge, and it goes oftentimes hand in hand with mental illness. A lot of young people who have ADHD, who don't get appropriate treatment for their attention deficit hyperactive disorder, will at some point in their life find marijuana, and that makes them feel normal because it allows them to focus. It causes all kinds of other problems, but when they smoke that for the first time, they think, oh wow, this is how I'm supposed to feel. There's a real tight link there between ADHD and how marijuana makes a person feel when they have ADHD and they haven't received appropriate care for that. It doesn't always have to be medication either. You can do a lot of good work with people in counseling and helping them manage different symptoms. And surprisingly enough, with mental illness, you can do a lot of really good work with people around what their diet is and how they exercise. When we have somebody come in and they're not suffering from a really major depressive disorder, we talk to them a lot about what do you eat? How often do you eat? How much sugar do you bring in? How much caffeine do you drink? Do you exercise? Do you get out into the community and talk to people? And depression is an isolating illness. So what we find is people isolate, they don't exercise as much anymore, they don't eat healthy, and that exacerbates their depression. So sometimes that's the first approach. Let's take a look at the food, let's take a look at the diet, and let's try and get you back out in the community and see if that can help the problem rather than providing medication. With adolescence, one of the things that we also know about adolescence is that the greatest risk period for somebody to be exposed to any kind of alcohol or drug is in your adolescence. And when kids are using around 18 to 22 years old, that's where we see the greatest beginning time frame for addiction. And right around 13, 14, this slide I think says 15 years, but right around 13 or 14 years old, where we're seeing kids beginning to use on a more regular basis, we see greater and greater risk of that person going on to have problems later in life. And there's a reason for that I'm going to talk about in just a second. 50% of adolescents will experiment with alcohol and other drugs. Now, I'm a prevention specialist. That was part of my background. When I was in New Hampshire, I used to travel all over the state and help schools and communities implement prevention programming. And our goal in my agency was we're going to put ourselves out of business because we're going to do all this prevention work, and that's going to, and one of the things that we learned is you can do the best possible prevention programming and kids are still going to experiment and use. And I'm going to talk a little bit about that in a second, about why that is. This is just another slide that shows in a graphic kind of a way that risk area between the ages of around 15 and your early 20s. As you can see, the spike goes up there. And what we see in that time frame for kids is that we see a lot of really risky behavior going on. So binge drinking, that's a pretty popular topic these days that people talk about, is that you don't have to, alcoholics don't have to drink every day. People can have a problem with alcohol or with other drugs if they're only doing it every once in a while. It's the amount of damage it causes the person's life that determines whether or not they have a problem with alcohol or other drugs, not the amount that they're using. Although, if you're using every day to a significant amount, you're going to have damage anyhow. So we have kids that are doing a lot of binge drinking, typically on weekends, weekend parties, stuff like that, or maybe once a month they'll go out and party and binge drink. The problem with that is that they then go into doing things that they wouldn't normally do because their inhibitions are lowered, and that is a real impact on alcohol. It also happens with adults. People think that alcohol relaxes them, makes them feel better, but what alcohol really does is it goes into your brain and it bathes it in alcohol, and it's a sedative drug, so it puts it to sleep. And your ability, because one of the first places it goes for is your frontal cortex, so your ability to reason and determine whether or not you can take risks and stuff like that becomes lessened. So you're not really relaxed, you're just being put to sleep. Which is an interesting thing about alcohol. Kids tend to have more injuries. Now, one of the things you'll also notice when you look at some of this stuff, risk-taking, who takes some of the greatest risks in our society? Anybody? Kids, teenagers. There's a reason for that. And I'm going to talk about that in just a second. I'm going to look at first we'll look at some internal risk factors. What causes somebody difficulty when we're looking at the potential for mental health problems and alcohol or other drug problems? They have their ability to cope and to handle different situations. This is where we start to see some interrelatedness between mental health and addictions. Somebody who's struggling with a mental health illness that's not being treated has a lesser ability to deal with everyday life and life's problems, which makes them more susceptible for alcohol and drug problems. So you can see that they kind of go hand in hand. We also see that people who are polysubstance use, means they're using a lot of different substances, puts them at much greater risk for any kinds of problems. A lot of times, you hear people that, say, well, I don't use drugs. I smoke pot, but that's a drug. Or I don't use anything, but occasionally I'll smoke pot. And then we'll ask them, well, do you drink? Oh, yeah, well, I have 3 or 4 beers a day. So what they're doing is they're actually polysubstance use is what's going on. They don't just level on top of each other, they multiply the effect that's happening in the person's brain. You also have the coexistence of psychiatric disorders. You can have depression with anxiety. You can have depression and be a substance abuse user. Somebody who is suffering from depression and drinking alcohol at the same time, alcohol is a central nervous system depressant. That's what it does. It depresses you. So if you have depression and you're drinking alcohol, you're making it worse. When you experience real trauma in your life and you drink as a response to that, you're actually exacerbating the depression because that's what alcohol does. And then there's some biological components to addiction and to mental health that we're starting to find more and more clearly in the brain. So this is one of the things I think is really neat. I love the research that we've done on the brain in the last 15, 20 years for a lot of reasons. There's a lot of stuff about brain research. If you just Google it to learn a little bit about what's happening in the brain, it's amazing. So one of the things that we've learned in brain research is that the brain is continually developing up until about your early 20s, which is interesting because what's the legal drinking age? It's your early 20s, 21. Now, it's a coincidence because we didn't really know that much at the time when we set that drinking age because, we went back and forth between 18 and 20 and 21 and all that kind of stuff, but we've settled on 21. But now we've got this scientific research that shows that the brain is still developing, usually right around until 22, 23, but it's still in pretty good phase of development there at 21 and prior. So what happens when you add chemicals, whether it's alcohol or marijuana or heroin or cocaine to the brain is developing and it's learning what it's supposed to be doing and it's learning how to function. And so it's learning to expect those substances to be a part of it. And that puts a person at much greater risk for addiction. So when we talk to kids about not drinking these days, we do talk a lot about the brain development. And the other thing that we know about the brain is they don't show it clearly on the slide here, but right down sort of in the bottom of the brain, you have the amygdala. And then in the front, that sort of red area there is the prefrontal cortex. So the amygdala is the piece of the brain that sometimes is referred to as the reptilian brain, sort of fight or flight kind of a thing. It is the part of the brain that is functioning really pretty well in adolescence. I want what I want when I want it. Anybody who's been around teenagers knows that they want what they want when they want it. They take risks, they do things, and they're supposed to do that because they're developing. That's part of their development, not only of their brain, it's part of their psychological development and growing and moving on in life. It develops earlier than the prefrontal cortex. The prefrontal cortex is the one that we have that's responsible for impulse control. So if you've been around teenagers or you are around teenagers, it starts to make a little bit more sense. So the prefrontal cortex isn't developing until later. So the impulse control isn't really there as strong in teenagers. And so, sometimes when you look at a kid and you say, what were you thinking? They weren't. They just weren't. The impulse control is there. I mean, I remember being a teenager and I just do things sometimes and had no idea why I was doing it. It seemed like it would be fun. I've had a lot of kids tell me that. Oh, I thought it would be fun. Okay. So that is one of the things that I think is the most exciting about that. And that prefrontal cortex isn't really developed until the 20s, until they're in their 20s. The reason that that's so exciting is from a treatment perspective and from a prevention perspective. It really helps us to understand where we need to focus our efforts in prevention and early intervention in somebody's use of alcohol or other drugs. And that becomes important. The other thing that we're finding more and more, which is really exciting, is that we're starting to see some early markers in the brain that show pretty consistently with a certain type of addict and alcoholic that they're actually finding a consistent marker in the brain. Not for all of them, but they're starting to see that in some. And they're beginning to think, maybe there really is something to the predisposed to be an alcoholic or to be an addict. And one of the things that you hear a lot in treatment that we hear a lot of, we talk to people and they'll say that, the first time I ever drank, the first time I ever used, the first time I ever whatever, in their addiction, it was like somebody flicked a light on. The switch was flipped and now I knew what I was supposed to be doing. And, we all thought that was interesting. Some people are just, maybe they're psychologically predisposed to do that. But now there's some evidence that maybe there is something in the brain that is genetically there that makes somebody more at risk for alcohol or other drug addiction. And what we're also finding with that is a real good connection to past family history of alcohol and other drug addiction. So if you know people who are from families that have alcohol or other drug problems in them, we talk to them about what that risk looks like. What we know is that it's about 4 times greater risk that a child who is from an alcoholic family will go on to have problems with addiction of some kind. And we talk with kids about that very clearly because they know their family history. Some of them might pretend that they don't know, but they got a pretty good idea what's going on at home. A little bit more on the adolescent brain. I'm not going to go into it at the moment. So then you have internal protective factors. And these are protective factors that we look for in how do we identify how to help kids, not only with alcohol or other drugs, but also with some mental health stuff too. See, that's the thing that's neat about the field in the field of addiction and mental health now. When I got in the field back in 1987, mental health didn't talk with addiction. They just didn't talk to each other. And there was an ongoing argument, do you treat addiction first or do you treat the mental health first? Do you have to stop the drug use and have that stop for a long time before you can start dealing with the mental health? Or do you deal with the mental health first and get that under control and then deal with it? And there's this long argument that was going on for quite a long time. With all of the research that we've done around treatment and around mental health and around addictions, one of the things that we found out is that you treat them at the same time. And that there's a lot of things that are similar and that go hand in hand with the two of them. So when we look at some of the internal factors, I'm not going to read each one of them, but the 4 big things that we look for is a commitment to learning, social competence, positive identity, and positive values. And when I talk with families, one of the things I tell them all the time is it's all about your values. If you have a commitment to learning and you instill that in your child as this is a core value of my family, their opportunities for success increase. And their chance for achievement increases. If we help young people learn social competence and how to interact with other people and set examples for them around what that looks like and how to be culturally competent, how to be accepting of people from all walks of life and stuff like that, what we find is that that young person goes on to have greater chance for success. Same thing with a positive identity. Criticizing young children and stuff like that we're finding isn't a very helpful way to get them to improve in their life. But if we celebrate their successes, you don't have to give them stuff. Giving kids stuff is not always the answer. Actually, it's one of the things that I prefer that we didn't do so much of. Unless it's your time, whether you're a grandparent, a parent, an aunt, an uncle, a caring adult, kids thrive on attention like that. And it's really important for them. And the more time they can get with their grandparents, their aunts, their uncles, and their parents, the greater their opportunity to succeed is. And the more we're putting in protective factors around addiction and mental health. And then positive values. I think it's important that people talk about values with their children all the time. And this isn't just addiction. I want to keep hammering that in. It also is around mental health. The child who feels good about themselves or has a sense of purpose or a sense of being in their family, it's easier for them to ask for help if something doesn't seem right for them. External protective factors are things that we can do in the community. And it's something that's really important in a community, particularly a small community like Nantucket. We can all impact what happens in our community by creating a community that is safe, where we value families, we value adults, we value seniors, we value children. We create caring neighborhoods. We put an emphasis on school and education. Same types of things that we do for an individual, but we do it for a community. Look at the community like it was an individual. And how do we do that? And how do we value our community? And how do we show that value for our community? How do we talk about our community with each other? How do we interact with our community? And what do we do in that community? What are our expectations of each other? And what are our rules, so to speak, in our community? And then providing people with opportunities of things to do. Now, kids are always going to tell you that they have nothing to do. You can always provide. I mean, I went to a conference once down in Orlando, Florida, and they said the biggest complaint they have from kids in Orlando is they have nothing to do. And their prevention programs were being given either half price or full passes to Disney and MGM studios and things like that, and the kids still had nothing to do. You know what they wanted to do? They wanted to ski. And I'm living in New Hampshire. I'm thinking, oh, all these kids want to come and ski. And in New Hampshire, they all want to go to Florida, to Disney World. It's just kind of one of those things that happens. So when you hear people say, I got nothing to do, just keep that in the back of your mind. Because believe it or not, there's plenty to do. You just have to engage people in that and get people out to do it and engage children in activities. And one of the things my wife and I love about Nantucket is that our kids have stuff to do all the time. And it's good stuff. And it's fun stuff. And there are days when you get bored, but that's part of learning how to live and cope with life. You get bored, what do? With our kids, we tell them read a book. And then they can go on an adventure. So symptoms of alcohol and drug use, I'm just going to sort of jump through these fairly quickly and tell you the ones that we look for most with any kind of a person is they begin to isolate a little bit. Their friendships change. They're not hanging around the same kind of people as they used to, adults or kids. Adults that are starting to have alcohol problems start having different friends than they used to have, or no friends at all. Adult men tend to do one of two things, spend more time at a bar or isolate. And adult women tend to isolate a little bit more. But we look for changes in patterns, normal patterns, sleep patterns. What are they doing? How are they engaging in the community? And you know what else? That works for mental health too. If somebody's starting to have problems with depression, for instance, we see their normal patterns and friendships and stuff like that begin to change. And that should be something that causes us to pay attention. Their dress changes. Literally changes. Somebody is having problems with alcohol or drugs, the way they wear their clothes changes. The kinds of clothes that they dress in change. Somebody who's depressed, their appearance changes. Maybe they gain weight, maybe they lose weight, maybe they don't bathe as often as they should. They look tired all the time because they're not sleeping or they're sleeping too much. All that kind of stuff is stuff that we look for. They start having absences from school or work. Now, with alcohol and other drugs, particularly with alcohol, Monday is a great day to look for a continual pattern because they're still hungover from the weekend. And so they're periodically absent on Mondays. They have the 24-hour flu, and they feel much better on Tuesday. Now we're finding that Thursday is being pushed as a real day to go out to bars, so Fridays too. So we have a Monday and a Friday absence to extend the weekend. So we look for patterns like that, and you can do the same thing with mental health. Somebody who's got some sort of a mental health disorder that's making it hard for them to interact with the community or with their job, they start missing more time. So the other thing that we're looking at is what kinds of research is out there. I mentioned that we have a lot of research around the brain and how the brain works. We have, in mental health, one of the things that's really kind of great about mental health research is that we're finding better and better and better medications to help people deal with different illnesses. And I have people tell me all the time, well, I have a friend who's depressed, and they had to try 3 different medications before they finally found one that worked, and that's why I will have nothing to do with a psychiatrist. I have been on 5 different medications for my cholesterol before they finally found one that worked. 5. It impacted my liver badly one way, or it didn't work on some other, some part of the cholesterol they were worried about, or it didn't impact triglycerides, or whatever it was that the doctors were looking for. It didn't have the same impact on my life that an antidepressant would have on somebody's life. But there are times when people, for different reasons, have to try different kinds of medication. You can't always get the first one and have that be perfect. Sometimes you have to work with it to find one that works. And it's the same with almost any kind of medication. My dad has diabetes. They've tried different kinds of medication for him to find one that finally worked and a dose that worked. And he also has to participate in his diet too, which, he goes by Dunkin' Donuts and everything goes out the window. So we're looking at that kind of research. We also know that addiction, particularly, and mental health also, are chronic illnesses. And by chronic illnesses, what we mean is that they're long-term illnesses. They're not something that just goes away. It's not like getting chickenpox or the flu or something like that. They're long-term, chronic, lifelong illnesses. And so there's going to be times when it might be worse if it's a mental illness, and there are times when it might be better. There are times when people relapse with alcohol and drug use, usually more so in the beginning of their recovery than later. And we've learned how to respond to that differently. It used to be if somebody relapsed to alcohol and drug use, they were bad. They made some mistake. They'd done something wrong. Now we look at it sort of like we do with diabetes. Okay, so what do we need to fix? How do we change this? What can we add to make this easier? How can we help this person be more successful with what it is they need to do to stay safe? And the other thing that we know about addiction and we're finding about mental health is that the more self-help that you can provide in a community, the better off that person's going to be. The sooner you can get that person to self-help, once they've identified their problem, the better off they're going to be. In addiction, the best, most valuable resource for alcoholics is AA. And as a treatment professional, I'll tell you that right out front. The most successful way for somebody to stay clean from alcohol over a long period of time is AA. They may need help in the beginning to get things sorted out and started from a counseling organization like Family and Children's, but AA is the ticket for long-term care and long-term recovery. Involvement with families is also something that is very, very important that we need to keep in the front of our mind anytime that we're working with somebody, whether it's addiction or mental health. Because if you treat just the person that has the problem, the people around them don't understand what's happened. Because they've gotten used to this person who's been either living in a depression or living with an anxiety disorder or living with an alcohol or drug problem, and nothing's changed. So we have to educate the family, and that becomes important. And what we've learned is families that are educated around the disease of addiction or mental health, the individual that's in that family has a much greater chance of success. And also helping children, if the children are there, to make sure that they understand what's going on. So some thoughts just to conclude on and then open it up for questions is that one of the things that we need to do is we really, really, really need to strengthen our prevention efforts. There was a great longitudinal study done from the late 1980s to the early 2000s. And what we found, and this was around alcohol and other drugs, and we make some suppositions that it might be the same with mental health, but around alcohol and other drugs, that when we spend more money in prevention, it makes perfect sense, but when you spend more money in prevention, the rates of alcohol and drug use in the country go down. Not at the same time, but a couple of years later. When alcohol and drug prevention money gets cut, the rates of alcohol and drug use go up. Almost in perfect coordination with each other. A couple of years later, we start spending money again, it comes back down again. We've seen it be tremendously successful with tobacco. I can remember going to places when I first got in the field, a meeting like this where people would be smoking. You'd never think of that now. You never think of it in most restaurants around the country now. But 20 years ago, it was perfectly commonplace. Prevention works. It works tremendously well, and it works very well with alcohol and other drugs. Treatment and prevention work very well with mental health as well. Mental health responds very well to appropriate and ongoing treatment, as does addiction. And we need to move beyond, and I think I talked about this, but it's something I want to point out, move beyond acute episodes and only focusing on an acute episode, so like a relapse to drug use or a break in whatever the mental health stability has been, an increased depression or something like that. We can't really focus on that. We have to look at the whole person and the whole experience of their life and move towards really focusing on what works for them in the long term. We all have things that don't work. I eat usually a very, very, very healthy diet. But I gotta tell you, I love ice cream. And when the juice bar is open, you know, my doctor could stand guard and I'd still find a way to get in there, you know? And I don't mean to belittle it, but when you're trying to live a healthy life, it's a simple example that I can give that sometimes we don't do everything that we're supposed to do. And that's just the way it is. And as a society, I think it would help with our problems with stigma and allowing people to get help for their alcohol or mental health issues if we could really focus on what do we need to do to help the person rather than what have they done wrong. And then the last thing is that I want to share with you just as a quote that we tend to really rely on oftentimes is that people are generally better persuaded by reasons which they themselves have discovered rather than those which have come into the mind of others. So when we do our treatment planning, and this is if you're looking for treatment anywhere, what you should ask is, how do you do your treatment planning? When we do our treatment planning, the treatment plan comes from the client, and we work with them on that. because most people aren't going to be successful with a solution that you give them. They're going to be successful with a solution that they are a part of. And then it becomes our job as the professional to help them enact that solution and make that successful for them. So thank you, and I'll take any questions if people have any.
Hold on a second.
I'm under the impression that abuse of prescription drugs is a bigger problem than alcohol.
Well, it's got more attention right now.
But the numbers aren't greater?
The numbers aren't greater. Alcohol has consistently always been the number one drug of abuse. But I'll tell you, I was just talking about this right when I came in with somebody. We do have a significant problem with prescription drug use. The number two issue probably on the island is marijuana, because a lot of people think that marijuana is legal in Massachusetts. It's not. I don't know the legalities around it, but because of some of the changes in the law, people think marijuana is legal. So there's a lot of marijuana use on Nantucket. But prescription drug use is a significant problem that we have, and it's almost always, not always, but a lot of the times it's focused on painkillers, OxyContin, oxycodone. There's also a use of a medication called Adderall, which is sort of like a speed drug, intense caffeine kind of experience. It's not caffeine, it's far worse than that. But it's used for a specific mental health reason. It's not to be used by somebody like myself. I would be abusing it if I were to use it. So we have this problem with prescription drugs, and people are getting a hold of them. Either they get a prescription because they injured themselves or something like that, or they're buying it from a friend, or they're stealing it from a friend. And what the real problem on Nantucket right now is not just the prescription drug use when it comes to this particular issue, but it's the transition from your opiate-based painkillers to heroin. Now, I was just talking to somebody earlier before this started about that we probably in our agency have about 30 to 32 people that we're seeing that have significant addiction to opiate drugs. Of those, about 19 of them are heroin users who are using IV drug use. And when we talk to them about how did you get to IV drug use at 20 years old? Now, when I came in the field in 1988, our heroin users were all in their 40s or 50s and had been using for a long time. Heroin had started to drift off in this region. Now it's made a huge comeback, and the reason is simply simple economics. Heroin is cheaper than prescription drugs, and the high lasts longer, and it's more intense. Those are the three reasons that people tell us that they get involved with using heroin and not prescription drugs. I save money because it's cheaper. I get a better high, and it lasts longer. And that's basic economics, right? You know, if you get something that's better, it's going to last longer, and it's cheaper, that's the thing that you look for. And it's, you know, it's simple, but that's really what it is. So that, when we look at the problem around prescription drug use, that's the thing that concerns us most, especially with the rise in IV drug use again. Because when you see a rise in IV drug use, there's three things that go with that almost always. Accidental overdose and death, HIV increase of infection, and hepatitis C increase in infection. And all three of those are really very, very unsafe to have on the rise in any community. And we're seeing it here on Nantucket like you would in any other community. Oh, wait, there's one over here.
Hi. I have an uncle that was allergic to food. He got drunk on anything that you could make liquor out of. If he ate it, rice, grapes, anything, you know, he couldn't eat the food. And he never knew this until he was like 70. And he had a lot of problems all his life. He had accidents and things like that. He was always fruit and stuff. So if these kids are drinking, plus if they have this, because little kids have this same thing.
Mm-hmm.
And if they knew ahead of time, they would watch what they ate, and if they drank, it wouldn't affect them as much as it would if they're eating foods that make them drunk anyway. He got stopped by the police for drunk driving, and he's never had a drink in his life. And yet, then they found this out
Yeah.
at the VA hospital.
Well, that's a new one to me. I haven't heard about that, but that would be a very difficult situation to try and deal with. And again, it comes around to one of the things that's really, really important for us to focus on is educating people about healthy choices, not only around do you use or do you not use alcohol or drugs, but around food. And educating people as to what's the impact of the food having in their life, particularly with kids. Kids who have ADHD and they eat lots of sugar or caffeine, bad idea. You don't want to be doing that. But we see people that do that with their kids all the time. Junk food and ADHD. No, you don't want to do that. It's hard to try and eat right. But once you start doing it, it's amazing how great your body can feel physically. And that helps your mood.
The percentage of the adult population subject to depression seems kind of high for America. Do you find the same percentage in other countries in your research or studies?
Well, it's interesting. A lot of the northern countries have higher rates of depression. Anybody have an idea why that might be? It's the sun. Just the further north we go, the more of an increase we see in depression. We also see some correlations around poverty and depression as well. So some of those countries will have a higher rate of depression. But we see a lot of that. And what more commonly is known as seasonal affective disorder is that people aren't getting enough light. And there's a lot of reasons that might be causing more depression for people in the northern climes where it's colder. They're not getting out as much. They're not interacting with people as much. They're not getting enough sunlight, vitamin D. They're not getting the things that they would normally get in the summer. And particularly on Nantucket, we see a lot of that. And I think you probably have experienced that with people, that around March, it can get kind of testy on the island, And then you run into the same people again, in May or June or July, and the weather's great, and they've been out on the beach, and everybody, oh, it's great, and you kind of forget about March. But that's an extreme example related just to our experience of it. But it is a little bit greater in northern communities, northern parts of the world, and then also islands tend to have a higher rate. The smaller the island, the higher the rate of depression, just because of isolation. So there's a real lot of effort that people need to put into to keep themselves actively involved in caring for their mental health.
Peter, that was a high percentage, 25%, and I'm just thinking of the physical medical treatment, which is pretty well funded, insurance and all that sort of thing. Is there a problem with funding all the treatment on the mental health side in general or on Nantucket?
Well, there is in general. There's always been insurance companies. When I first got in the field, I worked solely in programs that were grant funded. So I never had to deal with third-party insurance. In the last 6 years, I've been dealing with third-party insurance as one of our payers in ways that we get resources to fund some of our programs. And I'll tell you that one of the things that I've learned about insurance is that their goal is not to pay for anything. That's just their goal. They're not going to pay. And, I spent the better part of last Friday, almost the entire 8 hours, just researching 100 claims that had gotten rejected. And most of them for silly little reasons. And some of them were just rejected out of hat, and we had to resubmit them, and they were perfectly acceptable, but they just got rejected out of hat. So funding for mental health is very, very difficult. Funding for addiction is even harder. And a lot of those relate to stigma around that. Addiction oftentimes is seen as your fault, and that is permeated throughout the system, and insurances really don't like to be involved in that. When I was in New Hampshire, one of the reasons that I got so involved in advocacy was that I found out that at the time, insurance companies didn't have to provide care for addiction. They could just say, no, we're not going to provide any care for that, even though it's been shown to be a legitimate, recognized illness that responds very well to treatment. And the more times you have to pay for accidents and illness related to alcohol, the more impact that has on the insurance companies. You think they'd be able to figure that out by now. If we can stop the person from drinking, all of those other ancillary effects and impacts drop, and the insurance company actually saves money that way. But it's all about short-term gain, and that's very difficult.
Peter, do you have some thoughts about the possible impact that the marijuana dispensary that we're going to get sooner or later is going to have on your work on the island? And do you have some input on how that is going to be implemented on the island?
I don't really know very much about what's going on with the dispensaries, and I'll be honest with you, as a prevention and a treatment specialist, I haven't paid all that much attention to it. Since the law was passed, I stopped really paying much attention to it, and I'll tell you my reason for that is, it's sort of a lost cause at this point. We have clients coming into our agency all the time telling us that marijuana is not a problem because it's legal. And that's the way they view it. So we are shifting how we look at marijuana to how we look at alcohol. Approach it from a prevention perspective the same way that we approach alcohol. Does it have an impact? It has a huge impact. You know, we have numbers and numbers and numbers of people who are smoking marijuana now that don't have any thought about it being a problem at all. And it is. It is a problem. We know through research now that marijuana is addictive. We know through research that marijuana has a significantly negative effect on your short-term memory and your ability to retain information, particularly for students whose brain is still developing, high school kids. Really, really bad impact. There's a great study done in New Zealand that was done over long-term marijuana use that they considered chronic, and chronic marijuana use is smoking 3 times a week. It's what they used as their defining mechanism. Long-term being from adolescence to 30 years old, and they found a 5-point drop in people's intelligence quotient. Their IQ dropped 5 points. That's not a risk you want to take. It really isn't. And, you know, marijuana isn't just this wonderful thing, you know. I remember I was talking to somebody about that, and his response to me was, thank God I don't live in New Zealand. It's everywhere. It's just smoking in New Zealand isn't what does it to you. It's the marijuana, regardless of where it is.
One of your slides talked about evidence-based practices and practice-based practices.
Mm-hmm.
What is the difference between those two? What is that?
Well, what I prefer, and I can say we, because different people prefer different ways of looking at how you provide treatment. I prefer evidence-based treatment and evidence-based services. And what that is you're using programs and approaches that have been proven through research to be successful. Long-term longitudinal studies, multiple studies show that this particular form of treatment is very effective for this particular problem. And if we approach it from this direction, we're going to be successful. Now, part of the reason that I like that is I'm a big proponent that if it works, you don't need to fix it and you don't need to find some other way to do it. Just use what works. And if it is shown to be working, why not use it? Because we already know that it works. Somebody else has done all of the hard work to prove that it works. So let's use that, and then we're not wasting time, we're not wasting money, and we're not wasting energy. The last thing that somebody needs when they come into particularly addiction treatment is to be involved in a treatment that nobody knows whether or not it's going to work. When an addict comes forward and looking for help, they need to get help now. Because it's proven that if we don't have help available for them right then when they make that decision, they're going to go back out and use again, and it could be months or never that they come back. If they get involved in something that doesn't work, addicts tend to cling to that idea that this will not work for me. So that's why I am a very strong proponent of evidence-based practices. And practicing to see if something works. If we don't know that it works, we can be spinning our wheels. You know, it's kind of like one of the things I use with, getting stuck in something that's not working is you're driving out on the beach and you haven't taken enough air out of your tires. Everybody knows you got to take air out of your tires, but you've decided that you don't need to do it this time, so you go out onto the beach and you're driving and your wheels start to spin. And you're just spinning and spinning and spinning and not going anywhere. Your car's working harder, you're not making any progress, and you're getting further down in the hole. Whereas if you would use the evidence, which is drop the air in your tires down to about 13 to 15 pounds, you just drive across the beach. You're going somewhere, you're being successful, you're not taxing your car as much. So that's how I look at evidence-based practice. Find what works, see the evidence that shows it works, and then use that. the way that they say to use it. That's one of the reasons we've started using the Children's Behavioral Health Initiative approach of working with families at home, because the research is showing conclusively that it is more successful to work with children and their families at home than it is to work with them only individually in a one-on-one session once a week. The evidence is showing it conclusively. So we're switching a lot of our energy and focus in that direction. And we're finding the same thing that the evidence has shown. It's working very well.
We have one last question back here, and I
Sure.
think that's all we have time for today. And then if you have any further questions, please feel free to see Peter after the presentation.
And I do have business cards up here if anybody wants to have one to share or to bring home.
Recently, within the last year and a half, they've started doing a crisis intervention team on the island, and I think that's kind of worth addressing. And more so, NAMI has just started teaching courses on the island.
Yep.
And I'm the facilitator of the support group, so could you say something about it, and then I can hang around afterwards if
Sure,
you want
absolutely.
to say something. Thank you.
Yeah, let me touch on really quickly the crisis intervention team approach. We do have a contract for crisis intervention and crisis work in our agency, and the change that's come about in the last year and a half is evidence-based, and that's the reason the state really pushed it, and I agree with it 100%, is that it's more effective to intervene in somebody's emergency or crisis at home than it is to do that in the emergency room or the police department. Makes sense, right? You know, when you go into the emergency room, your anxiety is through the roof, whether you've got an anxiety problem or not. If you're in the police station, same thing. Your response to intervention is going to be less. If we can do that at home, we got a greater chance of success. So our team responds to a lot of home-based services now to divert from the emergency room or to assist with the police department so that they don't have to arrest somebody and bring someone down to the station. And that's extremely successful, particularly with kids. You know, trying to bring a kid into the police station for an emergency assessment or to the emergency room for an emergency assessment, that's not going to work. But if we can do that at home, that's very helpful. And then NAMI is the National Alliance for Mentally Ill, and that is a family-based program that works with families of people who have chronic and long-term mental illness, and it helps the families and loved ones to understand what's happening in that person's life better, but it also puts them in touch with other people who are struggling with some of the same issues. Some people who have lived with a person who's had a long-term diagnosis for a while, and then people who are brand new. So that there's a, very similar to AA, there's an ability to share with each other, some people who have learned through experience, and some people who are new, to come together and really share that experience. And when you're dealing with stigma, it's really, really helpful to have people in your life who understand exactly what you're going through. And I'll tell you, and I'm a treatment professional, this is what I do for my life. In many ways, for the family, it is more important to have the connection with another family or another family member who has a mental illness than it is to be connected to me or one of my clinicians. It might be really important for that person who's dealing with a mental illness to be connected with a clinician. But for a mom or a brother or a dad, the connection with another mom, dad, or brother can be more important, more helpful, and more rewarding than being in touch with one of our clinicians. Not that our clinicians are going to do anything bad to them, but it can be more helpful to them. And I think that, you know, the arrival of NAMI on Nantucket is one of the single most important things for mental health that has happened on Nantucket since I've been here, easily. Because that kind of support has not been around for a long time to the degree that it is now. And I have to tell you that it's done a tremendous amount of good already for families that we're aware of. And I applaud that effort. And if you're interested in knowing more about NAMI, certainly your name? Meg is right here that you can talk to. And that's how it works. It's somebody who is just like anybody else in the community that you can connect with and get more information. I can give you all kinds of research-based information and how mental illness works and stuff like that. But somebody like Meg, who's involved with NAMI, is going to be able to talk with you about how does this work in my family in terms that impact me on a day-to-day basis. That's a really valuable resource. Thank you for bringing that up. And thank you for having me.